Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs Research and Advocacy here at Lymphoma Canada. I'm pleased to welcome you all to the final session for today, titled COVID-19 Update for Lymphoma and CLL Patients. So many lymphoma patients are immunosuppressed for a period of time after cancer treatment. While the pandemic is over for many people, the risk of infection and illness is a reality for many lymphoma patients and their caregivers. This session will provide an update on what is important to know about COVID-19 and other infectious diseases for lymphoma and CLL patients in 2023. So before we begin, like usual, this session is being recorded and the recording will become available and we will notify you via email. At the end of the presentation, we'll leave some time for questions, which you can enter into the Q&A panel at the bottom of your screen. So without further ado, today we have here Dr. Versha Banerjee, who is a senior scientist at the Cancer Care Manitoba Research Institute. She's also an associate professor at the University of Manitoba and a clinician scientist at Cancer Care Manitoba. She co-leads the CLL clinic and is involved in several clinical trials and population-based treatment studies. As co-chair of the CLL research program, she manages a multidisciplinary research team in clinical, fundamental, and translational research. So thank you so much, Dr. Banerjee, for joining us today, and I'll hand it over to you.
Thank you very much, Gurjot. Thank you very much to everyone who is attending today, and hopefully you'll come back with a few simple messages. So as stated before, my name is Versha Banerjee, and I'm a physician scientist at Cancer Care Manitoba. These are my disclosures. I do participate in advisory boards to ensure that my patients get access to the best therapies possible, try and open clinical trials locally where possible, and serve as a principal investigator. I will not be discussing any off-label use of any therapies, and I do not have any conflicts of interest related to this talk. So, as was mentioned earlier, the last few years have not been the same, and this is particularly true for patients who suffer from lymphoproliferative disorders. And lives change for both providers, caregivers, and patients with the advent of COVID-19. So COVID-19 changed things for multiple different patients in different ways. And first was just learning what was COVID-19 and how this virus was really starting to change the lives of patients who were vulnerable, whether it was due to cancer, the treatment of their cancer, or other medical problems. But we do know that this had a severe impact on our population, specifically in patients with lymphoma, CLL, myeloma, or entities known as lymphoproliferative disorders. And we learned a lot, and that COVID-19 was not just one virus, and that this virus could take multiple different forms. And so we needed to understand what were the different types of variants that were circulating, which ones were actually of concern because they caused health problems, and how we can manage the situation in a global setting, and how we can protect our vulnerable populations. So what did we learn from COVID-19? We know that lymphoma patients had an increased risk, and this was often due to the fact that the white blood cells that are affected in this condition, whether it's myeloma, CLL, or lymphoma, are the very cells that create the antibodies that we need to fight off any type of infection. And so patients who had underlying blood cancers, specifically lymphoproliferative disorders, were at a greater risk and had a chance of a severe and prolonged infection, and were placed in this high risk category. We also know that this affected not just living with cancer, but also potentially the rates of death in this patient population. And depending on what type of lymphoma you had, your outcomes were different. And specifically, patients who had diffuse large B-cell lymphoma could have a worse outcome compared to those with follicular lymphoma. and the reported mortality rates were somewhere around 30%. But what this did allow us to do is come together at a global scale to try and develop strategies to prevent and treat and diagnose COVID-19. Three things that I think changed the lives of patients with lymphoproliferative disorders. But we had to learn a lot from this because we weren't sure whether our hospitals could accommodate all the patients to treat them for their underlying illness. Was it safe to do so? So there was tons of questions that we needed to answer in this space. So let's look at some numbers. So in this graph, I wanted to demonstrate that we in North America were not alone, and that this impact of COVID-19 was affecting lymphoma patients around the world. And so if we look at studies from France, Italy, Spain, Turkey, and the United States, the rates of the highest mortality were reported in Italy, followed by France at 35%, and in the United States and the UK, South Africa at about 33%. So if we think about this at a large scale, and this is prior to the advent of vaccinations being available, one of the things that we need to understand is that there was a large number of patients that acquired COVID-19, specifically those with blood cancers. And 55% of patients required admission during their illness. Sorry about that. One of the things that we need to understand is that patients with B lymphoid malignancies had the highest hospitalization rate at about 67%. But the mortality rates between the overall cohort and the B lymphoid malignancies was not that different. However, if we think about patients who had chronic lymphocytic leukemia, 72% of those patients actually required hospitalization, and 19% of them actually died. And so therefore, the outcomes for this group of patients as a subset of patients with B-cell malignancies was actually the worst. And those who were actually had either active or progressive cancers were the ones that were most affected, or people who were severely weakened or vulnerable due to their underlying cancer. And so I think it's really important to understand that prior to the advent of vaccinations and understanding the risk of transmission, our patient population was significantly affected by COVID-19. And patients who are receiving treatments are actually the ones that were found to have the highest rates of complications related to COVID-19. And so I know this is a complicated chart, but what I want to show here is the bars reflect the different spaces in which patients were seen with their COVID-19. The far left is outpatient, and the far right, as you get to the brighter reds, are the intensive care unit. And the maroon bars are actually death. And so this is in an era where we didn't understand the effect of our ongoing treatments and the ability to acquire and have complications due to COVID-19. So you can see patients who were only receiving anti-CD20 antibodies, so this is rituximab or obinutuzumab, they were doing relatively well, but did have a higher rate of ICU requiring mechanical ventilation and a significant rate of death. This is also true for patients receiving CHOP-like regimens. But what became difficult was the combination of an anti-CD20 antibody with chemotherapy. And this is when we moved away from the outpatient setting into the inpatient setting and to severe illness, potentially leading to death. And this was also true for BTKI or Bruton tyrosine kinase-based therapies, such as ibrutinib, acalabrutinib, that were potentially available at that time. So the important thing to take home here is in the time where we didn't have vaccines, your underlying cancer as well as your treatments could have affected your outcomes. But one of the things that we learned is over time, as we learned to understand how to manage the complications of COVID-19, but also protect our patients from receiving exposure to COVID-19 with simple strategies such as masking and the advent of vaccination, we actually could reduce the complication rates. So this is an early cohort of 254 patients compared to a later cohort of 120 patients, looking at the age of the early cohort compared to the later cohort, and the age at diagnosis of COVID-19 at the time. And so this patient population was definitely older than the later population. It was predominantly male and predominantly white. But I think overall, what I want you to take home from here is this is the percentage of patients who were either admitted to the ICU, needed pneumonia-specific imaging and supplemental oxygen and mechanical ventilation. And the proportion in the later cohorts that required this was less. And this actually led to better outcomes of the patients. And I think it's important as we learn and face these challenges, both as clinicians, but also as patients, that we could see that there was a more vulnerable patient population that was exposed earlier. But as time went on, we were able to support and understand the complications and treat patients appropriately, and they did better. So I do want to focus on chronic lymphocytic leukemia for the remainder of this talk. And the reason for this is that this was the patient population that was the most vulnerable, because we know that patients with chronic lymphocytic leukemia do not respond to vaccination appropriately. And so this became a significant issue in this patient population. So here is a study outlining how patients with chronic lymphocytic leukemia did in the presence of vaccines. And so this is a figure basically showing the ability to mount an antibody response in patients with CLL versus patients that are considered healthy subjects. And what you can see here is that healthy subjects do a great job of responding to vaccines, whereas CLL patients don't. And this was seen also in the ability to generate antibodies, an antibody response. Now, one thing I do want to share is we are using antibody response as a surrogate to the ability to protect oneself from COVID-19, but we don't have a direct measurement in terms of how much antibody is required to protect patients and if these antibodies are effective in CLL. We are using this as a surrogate measurement, but no one knows what the appropriate antibody level is for an individual person. And so it is used as a biologic tool, but that tool may not be clinically relevant. But I think what is a really important message here, and this message continues today, is that patients who have never received treatment have the best antibody response. The patients who are currently on treatment have a reduced antibody response. But people who are off therapy and in remission have even a better response than those that have CLL that is active but not requiring treatment. And people who are relapsed and not requiring treatment have a reduced antibody response compared to treatment naive patients. And the antibody response, as seen by the chart I showed you earlier, where the mortality risk was highest in patients receiving an antibody to CD20 or a BTK inhibitor, such as ibrutinib, acalabrutinib, and even today now, there's 2 other ones that are available either through trials or compassionate access programs such as zanubrutinib and pirtobrutinib. The antibody response is reduced. So this is to reinforce this, that the response to patients who are treatment naive is better than those who have had previous treatment, and even further reduced in those that are currently on treatment. And so which treatments negatively affect that response? And so we talked about the BTK inhibitors, and we talked about the anti-CD20 inhibitors. But what is very clear is that venetoclax actually does not impair that response. But when you pair it with a BTK inhibitor, you lose the response. And that's an important piece of information. So the next question people ask is, oh, I've already got 4 COVID boosters or 5 COVID boosters now. Are more doses better? And in chronic lymphocytic leukemia patients and patients who have a precursor to this, such as monoclonal B-cell lymphocytosis, the answer to that question, especially if you're not on therapy, is yes. So what we can see here is the same x-axis is seen on the CLL as the MBL. So post-dose 1, post-dose 2, post-dose 3, post-dose 4, and dose 5 versus pre-vaccination S protein levels. With subsequent doses of COVID vaccine, you can clearly see a response, and a level above 1,000 is considered an appropriate or a good response. And so you can see in patients with CLL, the more doses they got, the better that antibody response. Whereas in patients who had monoclonal B-cell lymphocytosis, there was actually very few patients in the study, but there's also very few patients that didn't achieve that threshold of 1,000, and there's only 3. But in those 3 patients, when they got subsequent doses or boosters, they tended to respond better. So in patients who are immunocompromised, if you've been newly diagnosed and you've never received a COVID vaccine, we consider 3 doses as the primary and subsequent doses as the booster. And this is also seen if you look at subsequent doses within patients who have never received treatment, patients who are off therapy in remission, patients who are off therapy and relapsing, and the patients that are on therapy. So what I want you to pay attention to, and I know this is a busy slide, is the red bar. And the red bar moves up with subsequent doses, demonstrating that you improve your antibody, your response to the vaccine with further doses. And this holds true for patients who are treatment naive, who are off therapy but in remission. Their response is already higher to begin with, but it improves with dose 3 onwards. And in those patients who are relapsing, you can really see that that starts to get better, but this number of patients is obviously small, so we can't draw significance out of this, but you can see the trend of this red line moving upwards. And specifically those patients who are unable to stop their therapy and require treatment. And so we are able to reassure them that more doses during this time may actually improve their response, which I think is a lot of new information that we've acquired over the course of these last couple of years, because these were things that we were doing. Everyone would put their hands up in the air and say, we think it's better, but we actually have systematic data now to support that. So I think this next set of information is practical information for you as a patient, because most patients who are being treated for lymphoma and chronic lymphocytic leukemia are being exposed to a monoclonal anti-CD20 antibody, either rituximab or obinutuzumab. Both of these have profound effects on your immune system that can last for months to up to 2 years. And so every patient is different, and it depends on how many doses of this monoclonal antibody you are receiving. So the timing of COVID vaccines, especially now as we are getting into the fall, where it is recommended that you get your flu shot and your COVID-19 next booster, is the timing of when you should get it. If you're not on therapy, you are able to get this at any time. You can get both the flu shot and the COVID vaccine at the same time. And whether they give it to you in the same arm or one in each arm doesn't matter. But the important thing is that you receive it. So, but the timing for rituximab does matter. If you have a time-limited course of therapy and you had it prior to the fall, the best timing for the most robust antibody therapy, antibody response or response to the COVID vaccine is about 4 to 5 months after the last infusion. If you're getting the rituximab routinely, either through maintenance therapy or because you're currently on treatment, 2 to 4 weeks prior to the next infusion is the optimal time. However, if you are unwell and you require therapy, we should not be delaying your treatment for your B-cell directed treatment. We should just get your vaccine done as soon as possible. And the same thing applies for obinutuzumab. It should happen at least 2 weeks prior. And in this particular case, the recommendation is that it's not given on the same day. And that is because of the infusion-related response that occurs because of a severe immune response to the obinutuzumab, as well as the COVID-19 vaccine. People might feel unwell, people might feel a little flushed, and these are all natural responses of your body to the COVID vaccine. And you can also expect flu-like symptoms and also enlargements of your lymph nodes, and your white count may actually shoot up if you have chronic lymphocytic leukemia. Now, this is available to your providers, and it is documented in the BC Cancer Center for Disease Control guidelines. The last thing I wanted to touch before my take-home messages for today is that we've learned that venetoclax doesn't alter immune response to the COVID-19 vaccine, and therefore it is safe to proceed as prescribed with your venetoclax-based therapy, and the timing might depend on whether you're getting an antibody with it. But what we have learned over time is that you might actually develop a better response if you hold your BTK inhibitor, if it is safe to do so with the blessings of your provider. And what we can see is if we interrupt the dose at least 5 days before and start up to 5 days after, 7 to 10 days after, you might actually develop a better immune response to your vaccine. And because these are continuous chronic therapies, it is not going to affect your disease response, if you're 6 months or a year out into this therapy. And so what we can see is that the response is better for the majority of patients if you interrupt the dose. And this is being recommended now as part of routine care for patients with BTK therapy. I think it's always important to test if you have symptoms, because you could be eligible for treatments, and which treatments are best for you depend on your particular situation and what therapy you might be on. And it is better to isolate if you have been exposed or if you're positive, and request a virtual assessment so that you do not expose others. So take-home messages: unvaccinated patients had higher mortality if they had a blood cancer, and that risk was greatest in those that had a lymphoproliferative disorder. Patients on treatment with an anti-CD20 monoclonal antibody or a BTK inhibitor had an even greater risk of mortality. Vaccine responses are attenuated in CLL patients and further reduced by those types of treatments. Receiving multiple doses of vaccines in patients can help improve antibody titers. and the timings of these vaccines should be discussed with your provider, in addition to dose interruptions with BTK inhibitors. So the main message today is protect yourself. Each person needs to assess their risk at an individual level. And since we're tracking less, the exposure risk still remains high. So when possible, mask, wash your hands, test if symptomatic, treat early, and ensure you get your vaccines. And with that, I thank you for your attention and am happy to respond to any questions.
Thank you, Dr. Banerjee, for that presentation. Just a reminder to the audience that you could put your questions in the Q&A box. So we'll get started. So the first question is, I got a mild form of COVID a month before my last rituximab treatment, which was eventually canceled due to the fact I ended up with pneumonia/inflammatory lung disease for 12 months. Finally feeling well, I have follicular lymphoma and was wondering if having this long COVID might affect my outcome from follicular lymphoma.
So that's a very difficult question to answer, mainly because we're still learning about long COVID and its impact on outcomes for multiple different types of cancers and medical conditions as a whole. The main issue is the effects of rituximab can be long lasting and very immunosuppressive despite not having exposure right now. And so even though you had a mild form of COVID prior to your last rituximab treatment, your immunosuppression is significant despite that. And this situation does put you at an increased risk and susceptibility because of what's happened to the lungs. And so you probably, amongst others, still need to protect yourself. And I'm very grateful that you're feeling well.
Okay, and the next question is, I received rituximab treatment in 2017. Would that still impact the efficacy of vaccinations for me?
So at this point in time, we would say that you're more than 2 years out. And if you are in clinical remission from your underlying blood cancer, that we would expect you to have a response as the general population. If you have CLL and it is active, then your disease may decrease the vaccine efficacy.
And what is the impact of RSV on lymphoma patients?
So this is a very interesting question. In the United States and the CDC, they are recommending RSV vaccinations for patients. In the Canadian environment, it's a little bit difficult to suggest whether we should be routinely recommending this. And a lot of this stems from the fact that it may not be covered for many individuals, and we don't have a lot of information. Because it is a vaccine, as long as it's not live, for the majority of patients, we could see ourselves recommending this in the future, and many seniors are being recommended to do so. And so I think it is something that we have to think about. I don't think there's any harm in receiving it, but I do think that we're still collecting data in this patient population.
Okay, and this person is asking, what about persons who are being treated with ibrutinib? I think they're referring to COVID-19 vaccine series rollout, because you mentioned it for obinutuzumab.
Yeah, so the BTKIs are ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib, which are available in the Canadian environment right now. So as long as your disease is stable and you're on maintenance routine, the data would suggest that if you got your vaccine on your continuous therapy, you would mount a response, but it might be attenuated. If you stopped your drug for about 5 days before and up to 7 to 10 days after, with the blessings of your provider, I am recommending this to my patients, but I would suggest that you have this conversation with your provider and make sure that they're on board given this new data. And I did put the reference in the slides, and the study was conducted at the NIH in the United States. And so their recommendation is to do the dose interruption for patients.
Thank you. And the next question we have here is, I'm currently taking zanubrutinib for 2 weeks now. Should I get COVID-19 XBB 1.5 vaccine?
So the 2-week period might be a little bit early to stop the zanubrutinib. And if it is for chronic lymphocytic leukemia, I would highly suggest you discuss with your provider. It could also be given for mantle cell lymphoma as well. And so I think the main situation is the timing. When patients are newly starting a BTK inhibitor in my practice, I usually ask them to be on it for about 4 weeks before I would add a vaccine, only because I don't want to see an adverse event related to the drug, especially if it's a new drug for you. In your particular case, I'm not sure that stopping is a good idea because you needed treatment. And so I would suggest that you would do the timing at least 4 weeks after the zanubrutinib, and then you could do the vaccine. And this is honestly gestalt based on practice, because we're still learning about zanubrutinib in the community for CLL, and the differences of reactions to it in this patient population. We have the literature to support, but patients can get neutropenic on zanubrutinib. So it is an important thing to make sure that the blood counts are stable and that you're able to take the vaccine safely.
Thank you. And next, the patient question is, if you have hypogammaglobulinemia treated in 2013, still in remission, how does that affect you if you get COVID? And they're referring to vaccination efficacy.
Yeah, good questions. I think there's 2 parts, and this person's asked 2 different questions. So I think I'll answer this in relation to COVID. So one of the things that are now available is the high dose influenza vaccine. And as I mentioned, the repeated series of COVID vaccine. I think initially patients, it was felt, at least in the CLL population, that patients would not actually respond at all to the COVID vaccine. I think we have now demonstrated with excellent data in multiple different scenarios that in this particular case, when it comes to COVID-19, patients can mount a response. Now, hypogammaglobulinemia, if you have not been replaced or treated, can definitely reduce your ability to produce antibodies as a whole. And this might be affected by the disease itself, the treatments you have received. But if you are, I do not know in this patient population that they screened what proportion of patients were hypogammaglobulinemic. We know the majority of patients at the onset of treatment with chronic lymphocytic leukemia also have a significant degree of hypogammaglobulinemia. And if they're able to mount a response serially, it may be attenuated, but it was still improved with multiple scenarios. So we would need more data to look specifically at the ability of patients with low immunoglobulins to be able to do this.
Okay, and we have someone asking, for someone on a BTK inhibitor, is there a better treatment for post-COVID diagnosis?
For someone on is there a better treatment for post-COVID diagnosis than another? Like, are they asking if there's a different treatment that is better if they have COVID? I think if the decision was made for a BTK inhibitor for the particular patient, there's often rationales, either the molecular testing, other comorbidities that went into that decision. And so it's difficult to say whether treatment should be changed just because of COVID. I think the reality is, as the exposures are becoming more ubiquitous, we're not using masks in the public setting, that patients are definitely more vulnerable, and that's why they have to assess their risk. And so there's a question about masking that I think I can answer at the same time, which is, oh, she wrote for Paxlovid versus other options. I see. So for the therapy of the COVID. So you have to receive COVID therapy within 5 days of testing positive. And what treatment you receive depends on what drug you have because of the interactions. People who are receiving venetoclax-based therapy and are too sick to stop their venetoclax need to get the intravenous remdesivir because of the interaction with Paxlovid. And if people are unable to hold their BTK inhibitor, they should get half-dose Paxlovid.
You mentioned you wanted to comment on masking.
Yeah, so there was a comment on masking on whether we should do it. I think patients who are currently on therapy are at high risk of COVID-19, and they need to protect themselves as best as possible. A lot of the healthcare systems are moving back to masking. Some of it is for the patient's safety so that they're not exposed to the people that we as care providers are exposed to, as well as other patients. And so I think it's in the best interest of the patients who are severely immunocompromised.
Thank you, Dr. Banerjee. That's all the time we have for today. Thank you everyone for joining and tuning into the second day of Lymphoma Canada's National Conference, and I hope to see you tomorrow. For now, I'd like to refer you to the closing remarks that are currently taking place. Thank you so much and see you. Bye.
Oh, thank you for all the positive comments.